Ventricular septal defect, VSD, is one of the most common congenital heart defects, accounting for about 20% of all congenital heart anomalies. It involves a hole in the ventricular septum, which is the wall that separates the left and right ventricles of the heart. This defect allows oxygen-rich blood from the left ventricle to mix with oxygen-poor blood in the right ventricle, leading to increased blood flow to the lungs. In VSD, the left to right shunt causes excess blood to be pumped to the lungs, leading to pulmonary overcirculation. This can result in increased workload on the right side of the heart and, over time, may lead to pulmonary hypertension and congestive heart failure if the defect is large and left untreated. There are different types of VSD, including paramembranous, muscular, inlet, and outlet VSDs. Paramembranous VSD is the most common, located near the tricuspid and aortic valves. Muscular VSDs are located in the lower part of the septum and may close spontaneously. Inlet VSDs are near the tricuspid valve, and outlet VSDs are near the pulmonary valve. The clinical presentation of VSD varies depending on the size of the defect. Small VSDs are often asymptomatic and detected incidentally by the presence of a heart murmur. Moderate to large VSDs may cause symptoms such as poor feeding, failure to thrive, tachypnea, recurrent respiratory infections, and signs of congestive heart failure. Diagnosis of VSD primarily involves echocardiography, which visualizes the defect and assesses the impact on heart function. Chest X-ray and electrocardiogram, ECG, may also be used to evaluate the size of the defect and any associated complications. In some cases, cardiac catheterization is performed to assess pulmonary pressures and the exact size of the shunt. Management of VSD depends on the size of the defect and the symptoms. Small VSDs may close spontaneously and require only observation. Symptomatic patients may be managed with diuretics, ACE inhibitors, and sometimes digoxin. Surgical intervention is indicated for large defects, particularly if there is evidence of left ventricular overload, failure to thrive, or pulmonary hypertension. Surgical options include direct surgical closure or catheter-based closure, depending on the location and size of the defect. The prognosis for patients with VSD is generally excellent, especially when the defect is small or surgically repaired before significant complications develop. Most children with a repaired VSD can lead normal, healthy lives. However, complications such as pulmonary hypertension, endocarditis, and aortic valve prolapse may occur and require long-term follow-up with a cardiologist. In summary, VSD is a common congenital heart defect with a good prognosis when managed appropriately. The approach to management varies from observation to surgical repair, depending on the size and symptoms of the defect.